Namaskar. Greetings from the AFPI, International Relations and Collaboration Committee. My name is Dr. Kamlesh Bhargava. I'm the chairman of this IRCC committee and will be your host today. And with me today, I have Dr. Lokesh Edara. Most of you might know them. Dr. Lokesh Edara is based in USA. He's an allergist and immunologist, but very passionate about family medicine in India. Not only passionate, but about advocate, also an advocate. He's a visionary leader and compassionate physician dedicated to advancing family medicine in India. With over 4 decades of medical expertise and a relentless commitment to patient-centered care, he serves as an inspiration to aspiring physicians and healthcare leaders. His professional journey includes being a physician, asthma and allergy centers, renowned for his expertise in allergy and immunology. Dr. Edara is committed to providing cutting-edge care for patients with asthma and allergic disorders. More importantly, for today's discussion, he's a champion of family medicine in India. Dr. Edara passionately advocates developing family medicine in India. So with that, welcome, Dr. Lokesh.
Thank you so much, Dr. Kamlesh ji, for inviting me and conducting the podcast, which is really get our word out, our work out to the world. Thank you so much, sir.
So to begin with, Dr. Lokesh, the first question I have is, why did you choose to pursue advocacy so passionately for family medicine in India, even though you have an background of allergy, immunology practice in the USA for the past 35, 40 years? What motivates you? What makes you tick? And that's one. And the second question is, can you briefly tell us about what is your knowledge or opinion about the Academy of Family Physicians of India, AFPI? 2 questions. Okay.
Thank
cool.
you, Bhargava ji. The main came is I came to America because I did not get a PG seat. It's very competitive. Even today, out of 220,000 MBBS students going for PG is only 70,000, 30% only getting postgraduate. That is the one I'm addressing. So compared, when I looked at the research rate, I looked at the UK, USA, and universal care, non-fragmented care. It is all leading me to the family medicine. Then I looked into, I came to India, and last 5 to 7 years, I'm working on this advocacy with guidance from AFPI. And I met all the big leaders of AFPI. And your AFPI is the best organization because as I'm looking from America, yeah, with the matured organizations in India, different specialties I have saw, but maybe majority of them DNB, maybe a lot of people came from UK, went back. The maturity of AFPI conducting their webinars, they're conducting their conferences, their lectures are so mature. That's why they're the faculty, already faculty is there which reaches them. That's why, and that's what my opinion AFPI. And about the family medicine, as I said, this is the one thing which is not only just a PG seats, it is a basic patriotic thing to do. It is a basic family medicine postgraduate to be under. Every family should be under a postgraduate of family medicine because MBBS are great, but they don't have enough clinical experience. Only 1 year, not enough. 3 years, then they can take care of it. This is a sort of solution, sir. That's why my passion.
Thank you. Thank you very much. So first of all, thank you very much on behalf of the AFPI for endorsing and validating what we are doing, especially from a third party like you. It makes a lot of meaning and boosts up our morale. And secondly, again, I would say I'm very impressed by your passion and dedication for family medicine in India. Well done. We look forward to much more collaboration and guidance from you. So the next question which I have is, let me see. What kind of advocacy are you doing in particular for family medicine in India? I know I've seen you in lots of forums dealing with the top officials in Delhi and calling them to over to US and hobnobbing, etc. But can you briefly tell us what all your efforts is and since how long? Over to you.
Absolutely. Actually, once I found these PG seats, and when I found the family medicine is essential, the department is not there. Unless your department, you don't get a postgraduate. So when NMC chair, because I came from the RP, American Association of Physicians of India platform gives me, is like a mother to us that gives the platform to communicate with the rest of the whole country, even though I'm from a southern state. So first I met Dr. Mehta, madam, and I requested her, I think through our friends. So when she came to Bengal API meeting, Madam, please make the mandatory family medicine. So from then, they keep on. We're asking any opportunity you give, we're presenting them. Then we presented to the NBME chairman, and they amazingly they increased the postgraduate seats. We're going to answer that question, whatever they can. Um, and with this information, one time at one of the night they asked me board of directors. I gave participate in the webinar to NBME, presented to them. It's actually kind of midnight for me, but daytime for them. And then I'm very fortunate to be invited to Niti Ayog and presented to NMC chair online, NBME president, and even VK Paul sir, and very leadership presented the need of the so then, of course, the AFPI, every time I was there, AFPI leaders, I'm communicating with them, and they're doing amazing. Because I'm not a family medicine doctor, but when I advocate, I have to double check with the AFPI, make sure I'm the right line. So that way, because it's a big country, just small change, any change in its government, it's very, very, it takes a lot of, they need to own it. It is taking time for us, but we are at it, and there is an issue. Family medicine is a needed one. That's the solution for universal care. That's the reason.
Okay. So let me summarize it to what I have understood, that you have presented all your proposals to the NBEMS, National Board of Examination for Medical Sciences, and along with the Niti Ayog people and the National Medical Council about creating 40,000 seats, right? And then, so that's the top down approach. And from the bottoms up approach is you are looking at colleagues and partners like AFPI doctors, individual doctors who can bring this up. So you are taking care of both ends of spectrum, from the administrators plus at the ground level, ground zero. Am I
Yes.
right?
And
Thank
also with this podcast, I also request the students who are the needed the postgraduate. They are the ones who are going to give the gift to their family. They also take the ownership and then request the policymakers advocacy. That will be the one which I'm requesting.
So we have to start a movement, and every Rome was not built in a day.
Right.
You need to cross thousands of miles, start with one step. So that's
Right.
where we are. So my next question to you, Dr. Lokesh, is: can you explain the challenges in postgraduate medical education in India compared to countries like USA, Canada, and UK?
You mean the family medicine comparing to the three countries? I will first mention about percentages. Say, for example, before I go in America, if there is MBBS students are 30,000, postgraduates are 40,000. So does Canada also 10,000, 20%. UK is even much higher. They have, I just looked at 9,000 local grads. They have 13,000 postgraduates. Out of them, 4,000 are family medicine. So in India, there are 120,000 MBBS. There are only 70,000. So we're producing only 50% of PG seats. So this is important. The family medicine percentage wise, UK, US, Canada is the highest number. There is a matching. You can go to the website, look at 40 to 45% of the PGs are family medicine. 45% of all PGs are in family medicine. That's why they can ask me, where you got this 40,000 number? This is where it is. America is a little bit behind in the universal care, but it's 13%, whereas UK is, as I said, 40%, approximately 35% of them. That's where I got the numbers, comparing the number wise.
Mhm. Okay, thank you.
Hmm.
Uh, Can you give us an update of family medicine postgraduate seats in India as compared to USA, Canada, and UK?
Yeah, that's what I just mentioned. And also in India, what we have is unfortunately, even though it's almost 10 years ago, it's initially started in Kerala, MD, only 24 PEG seats available and maybe 8, 10 colleges. But NBME did a great job. They're almost like, they created almost, don't quote me exact numbers. Let me check. I think I saw, I put it here. They're approximately, um, altogether, approximately 500 DNB diploma courses are approximately 560 when I saw before, and DNB 3 years program is 150. So around 500 approximately. But our goal need to be long when I compare to other, we need to go to 30 to 40,000.
Mhm. Okay. Very interesting. You seem to have done a lot of work. Now, the other question which I have for you is, what are the challenges and roadblocks in expanding family medicine, uh, according to your opinion?
Well, the challenges are because when the UK recognized this problem in 2000, they changed everyone to the main family medicine as a core, and India government policy makers recognizing warning, then it will happen overnight. So our persistence is a challenge, or we are persistent. I know the leadership of presidents, everyone is working with the NMC, Dr. VK Paul sir, even Abhijit Seth sir, everybody is positive, but how to give the ecosystem, how the policy even need to make even higher level. So how they will be making, even when I did COVID with our from Andhra Pradesh, our honorable chief minister Chandrababu Naidu sir, he is very very preventative physician, preventative medicine concept. He's a patient centric. He even developed his IT on patient developing in his towns and all the statewide eventually is coming. So this warning up and pushing, once they decided, it will happen overnight, and we are doing so challenges here.
So, Dr. Lokesh, listening to you, uh, now tell me, do you see, because you have been following this up, these family medicine programs for several years now, is there some changes, positive changes on the ground level? Yes, we have a long way to go. And from what you are saying, I understand that the political will is there, the desire is there with all whoever you have spoken to. But uh, for you or for family medicine, not enough action is seen on the ground. But in your opinion, are we moving slowly towards a certain goal, or there's absolutely total amount of resistance? We need something like a revolution to change things.
No, no, no. There is acceptance there. When I spoke to even past NMC chairs, sir said this can be done. The growth should be mainly in the 100-bed hospitals, government, I mean, hospital, private hospital. So the growth is there, the need is there. They, and they do believe it have. We made an impact on the policy, higher level, at policy level. It is an existent. Niti Aayog member, sir, VK Paul, sir, he started. He's the one visionary. He started already in every all aims one MD came. That is big thing. So, and we have to see how it is. Maybe if I have to ask one question, if everybody on one table, if you ask every medical college, at least 850 medical colleges, those who have MD, MS seats around 550. Please give one family medicine MD, DNB, or diploma and run a family medicine outpatient clinic. If we can do that first, then we have people there, then they show our activity, our action, then that will present. At least we should all come together, including students. We motivate them, ask them, maybe one day request across the country, sir, we need this one, we need the policy.
So let me understand this, because it was a long time back. I was in there in the medical school, probably more than 50 years back. We used to have a department of community medicine,
Yeah, that is
in
different.
which they did have a clinic in the outreach, but that is not what you
No,
did.
no, no. Community medicine, family medicine is a pediatric. Family medicine, OBGYN. Family medicine, community medicine in India is separate. Their curriculum, two separate curriculum in NMC. So we don't need to.
Right.
They're not. You cannot. They have their very goal. Their very work. There cut out for them. And family medicine is separate. Two
So,
separate issues.
do you think that any medical school has a family medicine clinic in their hospitals or universities?
Yes.
Do they
And
give
those
which?
medical colleges, which I requested, one of them, their owners, NRA Medical College, of course, all MD programs have the clinic. I spoke to doctor working there, and they run their family medicine clinic very well. They see a lot of patients there. They have two MDs joined now, and the seats are increased from 1 to 3. So that is a slow process. That takes 100 years if you go that way. No, we have to go a little bit faster. If
Oh,
Modi ji wants a Vikis Bharat, we are all patriotic, this has to be done. Otherwise, no universal health. Nothing will happen. This is very important. That's what my request to Modi ji, sir. Please make this family medicine PG seats mandatory. At least first step is just one MDP, DNB people move one clinic run in all colleges, at least if not MD college around 500. That's what my request direct to Modi ji.
sure, sure. Thank you. So, see, I know like the Baptist Hospital in Bangalore, Vellore, they have family medicine outpatient clinics. No, you don't
No,
agree?
no, they're okay. But the question is, if a village of 1,000 people, if you feed one people, what happened to the rest of the 999? So those three colleges cannot serve the rest of the country. I am for the whole country, every family, 140 billion.
I agree with you. I know that you are very impatient. You would like everything to happen yesterday, not today.
No, we wanted to want, I want to happen to everybody.
Okay, right.
When it happened, we do the work. Let the, like the Bhagavad Gita said, the work will, we do our job and the results will not in our hand.
Mhm, mhm. Okay. So moving on, is the family medicine postgraduate curriculum in US, UK, and India, is it the same?
Absolutely, they're all same. 3 years in India, 3 years program curriculum. I compared to the USA is structured program 3 years. UK also, what happens is their curriculum is 3 years, but they go to the doctors and rotate through. Yeah, all are 3 years. Canada has 2 years. They're moving on to 3 years. So bottom line is a physician need to have 3 years of clinical experience before they be
Okay.
graduated.
Yeah. To my knowledge and understanding, uh, family medicine is sort of community and country specific. So, what is, we cannot just import family medicine programs from other countries to India. We have to develop our own curriculum depending on what the needs of the population is. Do you agree?
Actually, no. First part is every human being is the same. The fragmented care is the same. Preventative care is the same. But India developed its own thing because, yeah, that's why. First part, no. Human beings are same and family medicine is same. But second part, yeah, India has some tweaking in it, but our own develop our own way, less expensive way. Yes.
Mhm. Okay. And then when we talked, you said that the family medicine programs are the same. Are there any differences in outpatient and inpatient rotations and durations in
Absolutely.
different countries, in US, UK, and
Actually, what I learned is, for example, I'm in internal medicine, general medicine, they have all 100% is hospitalization and the clinic together. But family medicine, UK, each 2 years they rotate through their general GP clinic. That is 24 months, and 12 months they rotated in the hospital. In America, I looked into that 50. So two-thirds in the outpatient, one-third in the hospital. That's what the UK model. That's what they give MRCGP. And average, they see one day, they see probably 10 to 15 patients. That's all. But the United States, 50% outpatient, 50% inpatient. But India, we're more towards the hospital-based, 70 to 80% and 20%. But if we make this mixture of UK model, we can produce these 40,000 in no time.
okay. Now coming to a different question is around the examination pattern. Is it different in these countries?
Okay, it's very simple. United States is unique. They do only theory exam. Once you take like 1 day exam, you pass, fail. 95% of them pass. But coming to the UK and Australia, and there may be other reasons, they put the theoretical exam is same, but practicality they put that OSCE's exam. In India also, they don't have multiple choice. They're essay-based questions, which are, in my opinion, they should move on to the more USA type assessment, and they have OSCE type exam. So it's exam is okay either way. I'm not that much. It's putting the PG training. One thing I want to tell you, a family medicine doctor in 3 years they deliver 150 babies. 150 babies minimum. In America, 30 is enough. So my family medicine PG is much more qualified than anybody in the world, anybody more than UK, USA, all to put together. One guy, one is better because they have more exposure. That experience is the precision I want to deliver to the rest of the country, including the rural, remote area, everybody. No MBBS 20 years from everybody, the family medicine specialist. That's all.
Mhm. Okay, so when we are talking about the family physicians, etc., uh, what do you think are the core responsibilities and scope of a postgraduate trained in family medicine?
Well, I think in our discussions, we've been mentioning I mean, family medicine is the fragmented care. People don't know. They go to the heart pain, they go to doctor. Maybe mild giant pain, they go to the orthopedic. They do a lot of tests unnecessarily. And and the poor country, developing country like India, don't have money to spend. The poor middle class, lower class. That's where the family medicine physician is really, really needed. And also, if there is a snake bite in the rural village and there is a clinic, they can awareness within half an hour. They're in the hospital, they can be saved that patient. That knowledge need to be percolated. In family medicine, the captain, all the so much ASHA workers, there are so many workers. They and also family medicine, MBBS education stops there, but family medicine education, AFPI will continuously try and restore their career. MBBS, they don't, there's nobody warn them and they don't have confidence. And patients don't come. There is an example, MBBS doctor coming in a clinic, only 5 patients come. But family medicine MD, 30, 40 patients coming into PSC. So, so correct, this is very needed. I think I don't think I can explain to you as your family medicine physician, but this is a you need to go to the real regular people. It should be vote bank, politics. Every 140 billion need to request this.
Uh, Thank you. And the last question is, today, if you are given all the powers and the government says, Dr. Lokesh, you make the program, how should we establish training of these family medicine postgraduate programs in the present infrastructure?
Awesome.
What would be your suggestions?
The infrastructure compared to the UK, USA, India has the best infrastructure. Why? There are 6,000 community health centers. There are 30-bed hospital and they have 100 outpatient. I went to the program director in my college. I told them number. You can give 4 PGs in family medicine. Our community health center with 30 bed and outpatients, they see much more patients than a GP in UK or Canada. And they are giving 2 trainee for 1 GP. And this is can put this 4 according to the numbers that is professionals given to me, and 6,000 times 4 is 24,000. And they have private hospitals which are there, and there are thousands of them. This 40,000 is not, but we cannot depend on only community. We need to have a medical college where the head will be sitting and they will be rotating, monitoring, virtual communication, monitoring. All those things should be done. They could be 1 month posted there, but there is continuous monitoring from, because nowadays every medical college is there in every district, so it's not too far away. So 3 months there, 3 months they can rotate through that. So 600,000 community health center, 1,000 area hospitals, and district hospital now most of them are taken by the medical colleges. So this is where we can develop 40,000 in no time.
Thank you very much, Dr. Lokesh, showing us that there's a potential that family medicine postgraduates can be trained in the medical colleges, private hospitals, district hospitals, uh, urban and rural health centers, and community health centers across India. It just needs to be structured, or there should be a governing body. That's a wonderful idea because we have the resources and the infrastructure is there. It just needs to be coordinated and organized better. Right?
And one more about I want Niti Aayog member, Honorable Dr. Dr. Vinod sir said every bed in the med India should be used for medical education.
Correct.
Dr. Vinod Paul said, sir. That should be the one. These pages learn from the patients, but we need a supervisor structure from medical colleges. Supervising them is a key. We just not give the program for CHC alone.
So thank you very much, Dr. Lokesh Edara, for sparing your time and giving us insights, some very valid points to dwell on. And I know at times you can be a one-man army spearheading all this, but we should from AFPI and other organizations should support to make it faster, quicker, and acceptable to all doctors. Thank you.
Thank you, sir. We owe to the every family in the India, and thank you so much. I think.
Namaskar.